Thank you, Sam, and thank you everyone for sticking around for the last session of the day. My name is Luis Andrade. I am a junior data scientist at Dime. Now I will be chairing this last session, which will be comprised of 6 lightning talks. Our first speaker is Karen Batt, the Policy Officer for the Global Partnership for Sustainable Development Data. She conducts research and policy analysis on data for development, particularly on population data. She also supports work on citizen-generated data. Karen has completed her MA in economics, specializing in health economics and public finance at the University of Dar es Salaam in Tanzania, and is currently based in Nairobi. Our second speaker is Kamil Shafiq, who is the co-founder of Pocket, a new tool for generating self-reported data and geo-specific insights in research. Kamil has presented at the United Nations General Assembly for his team's impact on SDGs 8 of decent work and 9 on infrastructure and innovation. He was selected as 1 out of 30 solvers by MIT for Pocket's approach to community-driven innovation, and is also one of 7 young innovators selected by the World Innovation Summit for Health. We then have Dr. Nadine Kohlers, who is a postdoctoral researcher at the Department of Biological Sciences at NC State University, and a member of NC State Center for Human Health and the Environment. Her work lies at the interface of engineering and public health, with a focus on characterizing microbial and chemical contaminants in engineered water systems and communicating scientific results to the public. She has received her PhD in environmental engineering in 2017 from the University of Michigan. We then have Joaquim Bale, a PhD candidate at UC Davis, working on environmental and public economics. His current projects focus on the distributional impacts of flood risk information and on the origins of inequalities in pollution exposure. Prior to his doctoral studies, Joe worked as a consultant at the World Bank's Environmental and Natural Resources Division. He holds two masters in environmental sciences and environmental engineering from Agro-Paris Tech in France. We then have Arthur Schnath, who works at the interface of artificial intelligence, robotics, and big data. He models big challenges related to space, oceans, seismology, and pandemics. He is a 2020 global winner of the NASA Space Apps COVID-19 Challenge from over 2,000 teams. And to close the day, we'll have a video from Mark Herringer, who is currently in a flight. Mark runs healthsites.io, which is building a baseline of health facility data with OpenStreetMap and brings human-centered design together with agile processes to drive baseline health facility data. Each speaker will have 6 minutes to present, and I will let you know when you only have 1 minute left. If we have enough time at the end of the session, we'll hold a Q&A, but we still encourage you to post questions on the Q&A box, as speakers can also see it and reply over that box. I will give the floor to Karen now.
Thanks so much, Luisa. It's a pleasure to be here. I have a presentation which will, I'll just share my screen. 1 moment.
We can see your screen, Karen.
Okay, great. So, yeah, as Luisa introduced me, I work with the Global Partnership. It's a network of over 270 organizations spread across the world, really championing the use of data and access to data to achieve the global goals. My presentation on my lightning talk this evening, well, it's close to midnight where I am, is really talking about citizen-generated data on antimicrobial resistance. And this is a project we're currently running in Kenya to the end of September. We're really trying to unearth how citizens' insights can help to address antimicrobial resistance. And just to set the scene, I have on my slide 3 quotes from key stakeholders that we're interacting with, bringing life to the importance of using citizen-generated data for antimicrobial resistance. The first one is the head of KEMRI. He's called Professor Sam Kariuki, and he sees AMR as a growing pandemic, quite similar to the current COVID pandemic, and poses a great challenge as most citizens and community members are unaware of the risks associated with over underdosing of drugs and buying drugs over the counter without a prescription. So really focusing on drug misuse and abuse. And also the 2 quotes from Wellcome are really touching on why it's important to look at other data sources beyond surveillance data. So the existing data collection tools in most African countries, and I think this could be, spread across the world, not just Africa, but the data collection tools do not collect or indicate the right type of data to inform decision making. And then it becomes a challenge to estimate the global burden of antimicrobial resistance. And lastly, an opportunity, and this is what our project is trying to do, is really get into a space to document the drivers to the purchase of drugs, to the use of drugs by citizens and community members, and then observe behavioral patterns around antimicrobial resistance. And I know I've used a term which is probably new to some of you. I've mentioned citizen-generated data, and maybe just to unpack. And I know the second presenter will also talk about citizen-generated data. But as defined, it's data that people or the organizations produce to directly monitor, demand, or drive change on issues that affect them. So it has to be issues that are pertinent to them, that are urgent to their issues, and then to their lives, and this is produced through different mechanisms. You can use technology, crowdsourcing mechanisms, citizen reporting, or social audits, and is often organized and managed by civil society groups. One key separation or one key difference of citizen-generated data is that it is actively given by citizens. So citizens know they're giving this information, and they know what they want this information, to help solve. So it provides direct representation of their perspectives, and is seen as a really strong alternative source of data to data that governments and international institutions collect. So going back to antimicrobial resistance, how are we doing this in Kenya? So as I mentioned, we started this last year, the last quarter of last year, and we're running to September. And we're working in 3 subnational governments in Kenya, the county of Kilifi, which is to the south of the country. We're working in Kiambu, which is to the central, and we're working in Bungoma, which is to the west towards Uganda. And what we're trying really to do is get communities into having conversations around antimicrobial resistance. What are the challenges? What are the issues? What are the problems that they face? And do they even know what antimicrobial resistance is? So we're doing this using community radio, and that's why you have a photo of one of the stations that we are having these conversations in. So we're doing 8 radio shows per location. So in total, 24 radio shows running for 8 weeks. And in those radio shows, we have key questions that we're asking, and we have an opportunity to allow citizens to dial in or to send their feedback through a free SMS service. And we also have something we call listening groups, where we have community members come together as groups and listen to the radio show together and then have a conversation around that. So I must say we just right in the middle of the radio shows at the moment, and sort of starting to see key findings or key things that are coming out of that data. And this is my last slide. What are the results so far? I must say so far, because we're not done with the project, but there's clearly a gap in community health knowledge when it comes to the use of antibiotics, or even just understanding what antimicrobial resistance is. In addition, there are key barriers that make or that propagate antimicrobial resistance. One is cost, and one is the infrastructure or access. And when you talk about cost, it's just people prefer to buy drugs over the counter rather than go to a hospital, queue, pay for consultation rather than just go to a pharmacist and buy the drugs over the counter. So what it means if you're buying drugs over the counter, especially in most developing countries where drugs are not, dispensation of drugs is not as regulated as it should be, then you either, you get misdiagnosed or you're given the wrong prescription. And as in order to get prescribed antibiotics or medication for infections, you need a blood culture or a laboratory test. So obviously, when you're going over the counter, you're not having that, but you're just being prescribed medication which may not be right. And you also find that citizens are not following the required doses. So you go to a pharmacist, you're told you need to buy drugs for 5 days. You can't afford 5 days, so you say, give me for 2 days. If I feel better after 2 days, I never go back. I'm okay. Why should I go back and take more drugs? And as I wrap up, it's just also the limited access to health facilities. So that means no appropriate diagnosis and no correct prescription. The long queues and the workload of health professionals also limit the ability to be antimicrobial stewards. What do I mean when I talk about antimicrobial stewards? They are, health practitioners should be guiding citizens, should be guiding communities around misuse of drugs, overuse of drugs, or even the abuse. But because of the workload, they don't have the time to prioritize stewardship. And lastly, it's just the inadequate record keeping, and this really caught my attention as something that is coming out of citizens, from feedback from citizens, that inadequate record keeping at the health facilities means if I am a repeat patient in a health facility, chances are the hospital does not have my records. So it's not clear what was prescribed to me the previous visit and what I was ailing from. And so that inadequate record keeping means that probably I'm overusing drugs, or the doctors are prescribing the same drugs, which may not be, improving my life. That's my last slide. I just want to sort of touch on and saying that we see citizen-generated data as a really powerful tool, because it brings in the nuances that you don't get from surveillance data, from official statistics and government systems of collecting data. So it is definitely very powerful in terms of enriching official statistics and complementing. I think just as I finish, Louisa,
Thank you,
what's
Karen.
the bigger picture?
Yeah, just in the interest of time, I'm going to ask you, but feel free to add any more comments that you may have on the chat, but we can come back and to your point if we have time at the end of the session. Kamal, I will pass the virtual floor or the screen to you now.
Thank you so much. And Karen, I really loved your presentation. I think it was such an excellent primer for mine. Are you able to see my screen and everything? I hope so.
Yes, we can see it.
Great. So yeah, I'm just going to jump in just in the interest of time. And Karen, again, thank you for such a great primer. My talk is also really reminiscent of a lot of the ideas that Karen mentioned. So really, before I jump into our work at Pocket, I want to kind of paint the picture as to why we believe that self-reported data and citizen-generated data is going to play an increasingly important role in the world of global health research. So the first one, as everyone knows, the pandemic has really disrupted traditional forms of enumeration field research. Right, it's become really difficult for a field researcher to take public transit or go into a foreign community or have a face-to-face conversation with a household or a research subject. And a lot of researchers have, for that reason, needed to turn to things like phone surveys, where we lose a lot of richness and color in the data. The next thing is that high frequency data has always been really difficult to obtain, right? It's really difficult to send someone into a community or household on a monthly basis or on a weekly basis, or dare I say it, on a daily basis. And the next thing that Sam also alluded to this morning is that internet penetration across the global south is really just skyrocketing. And the majority of new internet users are accessing the internet through low-cost Android devices and smartphones. And as a byproduct of that, we're also seeing this leapfrog phenomenon of a lot of traditional banks being displaced by folks actually accessing financial services for the very first time using a mobile wallet. So we think that all of these factors together kind of create the perfect storm for a tool needed to kind of increase the amount of self-reported data and citizen-generated data that we can deploy. And that's really our focus at Pocket. So we're a group based out of MIT Solve program, which is a relatively new group within the university focused on cultivating innovations, moving the needle on the Sustainable Development Goals. So our kind of subcategory within that is community-driven insights. And what we essentially do is offer up this tool primarily for smartphone devices that we customize for research projects. And then the researchers basically put these tools in the hands of the community members that they work in. So the community members can actually generate data and also receive rewards for it if it makes sense. So the ideal use cases are things like self-reported data, participatory research and mapping, and of course, beneficiary and citizen-generated data as well. And when we think of crowdsourced data, we like to kind of lump it into these two distinct buckets, right? The first are things that are tangible and observable, right? Things like mapping disease vectors or open defecation, or insects and pests and safe spaces for minority groups that are disenfranchised, healthcare sites, which you'll hear quite a bit about today, informal merchants. And then the other kind of category are things that are a little bit more abstract and intangible, right? These are things like sentiments, perceptions, attitudes around a trial or an intervention, things like self-reporting quality of life indicators or dietary habits or mental health states throughout an intervention. And so when we look at all these use cases, we've kind of created a platform or a tool where we customize our suite of kind of tools for a research project and then hand them off to a researcher who then deploys them in the community that they're working in. So just very quickly, I'm going to fly through just the way our tools work. The first is really the tool that's used by the community member or the citizen. And it really serves three key functions. The first is to allow them to actually enter data, which you've probably seen in any kind of data collection tool. The next feature, which can be turned on and off, is focused on allowing users to see one another's contributions. So in this case, it's participatory mapping of pharmacy. So when one person or one user maps a pharmacy, another community member can see that a pharmacy exists in this part of the community, and B, they probably know that they shouldn't duplicate that data or map it once again. And the third key function is this idea of incentivization or gamification. So what we've kind of created is this abstract system of points where users get rewarded these points and researchers decide what they want these points to represent in the real world, right? So it could be things like mobile money, gift cards, prepaid airtime credits, digital currency, and in some cases it can just be nothing. It can just be a fun way to incentivize and gamify the experience for community members. There's some other bells and whistles here, but just to fly through it for the interest of time. The second tool is really focused on data verification. So this is what the research team would use, also an Android app. Usually it's a PhD student or potentially even another community member who's basically screening the data that's generated from the field. And so when they accept the data, that's what really triggers these points and these rewards. And when they reject the data, the user in the field gets a bit of a nastier message that tells them they haven't really done a good job generating the data. And then the last tool is essentially a dashboard that allows the researcher to look at not only their data in real time, but also kind of the activities of the contributors and the participants that they're activating. And of course, it also shows you any information needed for issuing any rewards. So with that said, I just want to spend the last minute and a half that I have focusing on, or just giving a little bit of an overview on some use cases that we're working on. So the first one is an international NGO that's focused on global health. And what they're doing is activating a group of mostly young unemployed women in urban Bangladesh to, at their leisure, map health sites and also receive rewards for it. So basically, at their own convenience, these women, when they see a health site, they can enter in some details, take a picture, and they'll receive a Bcash transfer, which is essentially the mobile money scheme that's most popular in Bangladesh. And in this way, they're not only decentralizing data collection across an entire city and hundreds of people, they're also creating this supplementary form of work where young women who have been disenfranchised or unemployed at the community level are generating data and earning some side money for their contributions. The next one is focused on citizen-generated data in Mexico, and this is a COVID-19 use case where the citizens are actually tracking COVID-19 public health measure compliance with food merchants and small merchants across the city. So what they're basically doing is almost a social audit of which merchants are wearing face masks and which ones have clear access to hand sanitizer. And again, it's citizens that are at their leisure, at their convenience, kind of checking into these stores, entering data as they see it and being rewarded for their contributions. Again, very decentralized, really hard to do a study like this when you have a small team of enumerators. And then the last use case, as I'm just timing out here, is what we were kind of talking about earlier around high frequency data collection, right? So this idea of allowing a participant in a food and nutrition intervention to self-report their meals or daily dietary habits, right? Kind of creating this really interesting granular picture of what a user or what a community member is doing on a day-to-day basis, and of course incentivizing them to do so. So that was my very quick spiel. You know, we're really, really grateful for CEJA and the DAM group at World Bank to give us this platform. And if there's any researchers who are interested in kind of learning more about this tool, or might have some colleagues that might be interested, please do drop me a line. And yeah, regards from snowy Toronto.
Thank you, Kamal. And for those of you who are interested in using this tool, we will also share a survey at the end of the conference where you can express interest in being connected with any of the presenters. Pass the screen on to Joaquin.
Great. Can you see my screen?
Yes, thank you.
Awesome. Well, thanks a lot for coming to this talk. And thanks a lot to the organizers of MeasureDev. So this is a very interdisciplinary collaboration with Mike Springborn, Karen Lips, Roberto Ibanez, and Aniruddha Ghosh. And so the idea for this talk really started by looking at the impact of the dynamics of malaria in Central America over the past 2 decades. On this plot, you can see time on the x-axis and numbers of new malaria cases in thousands on the y-axis. And you can see that there was a sharp increase of malaria cases in the 90s, first in Costa Rica, followed about 10 years later by another outbreak of malaria cases in Panama. And at the same time, ecologists have been noticing that amphibian populations were really collapsing over the place. And again, different species groups have been collapsing in the past decades, but if you look at this figure on the left from the IPBES report, amphibians populations were especially impacted and more impacted than mammals and birds that we tend to hear more about. Furthermore, amphibian populations were especially impacted in Central and Southern America, as demonstrated in various several studies. So the question that we are asking for this project is really quite simple. Did amphibian declines increase malaria cases in Central America over the past in the past few decades? And it's not completely crazy to think that this could be the case in the first place, because amphibians are serious mosquito predators. And so the causal chain that we have in mind is that if you have declining amphibian populations, this could lead to an increase in mosquito populations that then transmit more malaria. And we would pick up an increase in malaria cases at the end of the chain. Now, identifying this mechanism is quite challenging for several reasons, but in particular because we worry that there might be unmeasured confounders or things that we are not accounting for that are driving both amphibian declines and malaria cases. What is going to help us a lot here in this context is that in Central America, amphibian collapses were really driven by an invasive species called BD. It has another unpronounceable name. And BD is a fungus that really lead to a collapse of amphibian populations upon arriving in a region. And over the 80s and 90s, there was a large team of ecologists led by Karen Lips, who is a co-author on this study, that have been tracking the wave of BD-induced amphibian collapses over Costa Rica and Panama. And these collapses of amphibian populations had this really striking spatial pattern where populations started to collapse in the late 80s in northern Costa Rica, and then slowly started to collapse further down south Costa Rica and then Panama. So we use these samples collected by the team of ecologists to calibrate a model of spatial spread of the disease and of amphibian collapses, to be able to predict the date of amphibian declines over all counties in Costa Rica and districts in Panama. We also digitized 40 years of malaria records from various public health institutes, so really less fancy data collection methods than what we've been seeing so far during the conference. And we are not super worried about remaining confounders due to the exogeneity of the BD invasion, but we still control for land use changes and monthly weather patterns using these two publicly available and really easy to use data sets. Finally, we put everything in an event study framework where, again, we're interested in looking at the impact of amphibian declines on malaria cases per capita here on the left-hand side. I'm not going to dive into all the econometrics details here. And setting them aside, what we noticed is that right after the decline of amphibian populations, we estimate an effect on malaria cases that increase and tends to peak after 5 years. And the effect is of about 1 additional cases of malaria per 1,000 inhabitants. And this effect then goes down after 10 years. And we hypothesize that this is due to the public health response that starts to kick in both countries. To conclude, we used the natural experiments to study the impact of amphibian declines on malaria at a fine spatial scale. And we did that combining public health record with an ecological model, as well as satellite data. We estimate the effect in an event study model and find that there's a strong, significant, and dynamic impact of amphibian declines on malaria. And we think that this has potential implications for conservation policies, as well as trade of live species policies. Thank you for your attention, and I look forward to your feedback.
Thank you very much, Joaquin. For our last speaker, please join me in welcoming Artash Naz. We can see your screen.
Hi, yeah, that's great. Hi, everyone. Good evening or good afternoon, depending on where you are. Hi, I'm Artash, a grade 9 student from Toronto, Canada. And today it's my pleasure to be sharing about one of my most recent studies on measuring the reduction in human movement during COVID-19 lockdowns using open seismic data. On 11th March 2020, last year, the World Health Organization declared COVID-19 a global pandemic. And one common tactic that all countries used to approach and combat the spread of COVID-19 was lockdowns. Lockdowns cut down on non-essential business, travel, shut down schools. I haven't been in school for the past 1.5 years or so. But these lockdowns are essential to stop human-to-human transmission of the virus. But these lockdowns are only effective if citizens comply with the restrictions. So my big challenge was, how can I measure the reduction in human movements in real time during these lockdowns? Because this would help to understand whether the lockdown legislations are actually working. It would allow policymakers to enforce surgical lockdowns based on time and location, and allow health workers to predict spikes in COVID-19 cases and move testing equipment and testing kits to those locations to prevent the collapse of our healthcare system. Canada was no different from other countries. I live in Canada, and a few weeks after 11th March 2020, all provinces were under some sort of lockdown, and the Canada-US border was closed. So to measure these changes in human movements above the ground, I actually decided to turn to seismic vibration data below the ground. So seismic vibrations are measured using seismic stations, and they are extremely sensitive to ground vibrations. Seismic stations are usually used to measure earthquakes and volcano eruptions, but since they're so sensitive, they can also measure urban noises, such as ones from trains, traffic, mining, and construction. But these stations are also built far from cities, because the whole point of a seismic station is not to pick up the human noises. But in my case, I wanted to reverse this. The challenging part was to separate the seismic vibrations caused by human reasons from natural reasons, which would allow me to get a good idea of the changes in human movement during the lockdown. The best part is seismic data is free, open, available in all countries, and it does not impinge on anyone's privacy as it does not track individual people. Throughout my process, the first part was to download the seismic data. And for my study, I chose to sample 13 stations located close to cities in Canada, including some major cities like Toronto, Ottawa, and Montreal. The next step was very interesting because one thing is that human vibrations caused by these human reasons happen at a high frequency of 4 to 20 hertz. But vibrations caused by natural reasons like earthquakes happen at a lower frequency of 0 to 2 hertz. So I coded an algorithm in Python that uses power spectral densities to break the seismic vibration data into its frequencies. And then I kept only the ones in the 5 to 20 hertz range, which is caused by human reasons. I then compared the high frequency seismic vibrations from during the lockdown to before the lockdown, and I got some really interesting results. First, I got that my methodology was correct. In all 13 cities of my study, seismic vibrations decreased from 12 to 55%, and all of them decreased simultaneously. Even more interesting, now during the weekends in the lockdown, there's several things that were not running, like usual things that you would do on a weekend, like go out to the movies or go to watch a sports team. It was not valid during the lockdown. And for sure, all the seismic vibration levels on weekends were much lower than the seismic vibration level on weekdays. Weekends were on 30 to 50% lower than weekdays. Now, from both of my results, there are several conclusions that I came up with. First, that anthropogenic seismic vibrations are a good proxy for human movements, and I validated this. I looked at the change in human mobility trend from mobility data that's given by Google, and I found that the decrease in seismic vibration I had seen for all my cities in Canada corresponded with the drop in human mobility offered by Google. In addition, I can use seismic vibrations to pinpoint the source of the seismic vibrations by looking at the weekdays versus weekends. Now, this project was really interesting, and I started reaching out to several people, and I got queries from researchers all around the world and support. So I decided to expand this project to other countries. I started by expanding the project to countries like Spain, Argentina, Brazil, and Poland, all countries of which were experiencing a rise in COVID-19 variant cases. And these drops in seismic vibrations was very similar to the one seen for Canadian cities. Now, to make all my results public and more accessible to policymakers, health workers, and citizens, I created a web app, Monitor My Lockdown. MonitorMyLockdown.com allows you to pick any city off the map. Like for example, here, I've chosen Ottawa. Then it gives the most recent change in human activity in the past month, allows you to see what is the difference between weekdays and weekends, and allows you to view the decrease in seismic vibrations during the first lockdown. I even created a tutorial on GitHub that makes my code open source, so that anyone around the world can replicate the same results I did and monitor the effectiveness of their lockdowns in their own cities and countries. Finally, I've been releasing weekly updates on the changes in human movements that I've been sending out to the media and members of provincial parliament. In fact, my website was even featured in national news and newspapers. And at the end, I even got the opportunity to talk to Seamus O'Regan, the Minister of Natural Resources in Canada. Thank you. Looking forward to any questions.
Thank you, Artash, and thank you everyone for all these very interesting methods. I am super curious about all the different tools that you're using, and I had a lot of questions myself. Unfortunately, we are already over time. So I will ask you to please answer any questions that are addressed to you on the Q&A box, and I will let Sam take over to share a video from our last presenter.
Whether we are dealing with global pandemics, local disease outbreaks, or day-to-day health needs, we need good data to make a difference. HealthSites is building a baseline of health facility data with OpenStreetMap. Find out how you can participate. Maria needs an ultrasound scan. She needs to know where she can get one in her area.
Medical and humanitarian organizations such as MSF need to understand the spatial distribution of public health systems for planning and monitoring their interventions.
HealthSites is a global initiative to build a baseline of health facility data with OpenStreetMap. HealthSites facilitates contributions from volunteers from around the world to improve health facility data in hard-to-reach places. Local mappers, including nurses, doctors, and stakeholders in the health cluster, help us geolocate health facilities and list services available, all on OpenStreetMap. The availability of this data enables humanitarian organizations and the medical community at large to build upon this information and help keep it up to date. HealthSites launched in support of the Ebola outbreak in 2014 and partners with leading organizations in the field to improve baseline health facility data. Data which helps these organizations prevent, predict, and respond to disease outbreaks. It also allows governments to update their often out-of-date health facility data, which in turn helps them with their health capacity planning. And it helps individuals access healthcare when they need it, saving time and lives in the process. Get involved. Become a mapper in your community. Share existing data or support HealthSites financially. Your donation will fund on-the-ground mappers that will get the job done, providing critical information where it is needed most.
All right, I think that's our last video of the day. That was courtesy of Mark Herringer at HealthSites. Yeah, thank you, Louisa, for moderating our lightning rounds, and thank you to all of our panelists for a really, really interesting set of tools, research, and projects around global health data. We're really, really thankful to have you all. And yeah, I want to remind everyone who's still here that we'll be we have our second day of the conference tomorrow, in which we'll have workshops organized by Esri and Atlas AI, as well as a number of other panels on global health data and mental health, and a panel of policy experts invited by Esri. So take a look at the agenda, and we're looking forward to seeing you all tomorrow if you can make it. And again, a big thanks to all of our speakers today and our lightning round speakers. Thank you.